Hello everyone. I am Dr. Rajni Peter and I am the coordinator of Maternal Nutrition Technical E-Dialogues at ICMR NIN. Greetings of the day. In 2015, the International Federation of Gynecology and Obstetrics, the FIGO, developed the FIGO Nutrition Checklist, a simple nutritional questionnaire with a goal to gather basic information regarding diet and weight from women through a series of brief questions. These questions are designed to help women and healthcare professionals to have a healthy dialogue on nutrition before and during pregnancy. Welcome to the 7th session of the Maternal Nutrition Technical E-Dialogue series on the FIGO Nutrition Checklist. It's a privilege for me to be able to guide you through the excellent talks and discussions we have scheduled for today. As you may be aware, the ICMR National Institute of Nutrition, UNICEF, and FOXI are jointly hosting the Maternal Nutrition Technical E-Dialogue series with the theme Strengthening the Maternal Nutrition Assessment and Services in Antenatal Care in India. We are glad that all of you have joined us today. We thank FIGO, particularly Professor Hansen, Professor McAleef, and Dr. Jacob, as well as FOXI, the Federation of Gynecological and Obstetrical Societies of India, Professor Shantakumari, and Dr. Hema Divagar, for their excellent efforts in organizing this e-dialogue. We appreciate our partners, Sight and Life, Alive and Thrive, International Food Policy Research Institute, Society for Applied Studies, and the Institute of Economic Growth for their participation and help. If any one of your colleagues are not able to join this webinar today, the recording of the e-dialogues will be made available in the ICMR NIN YouTube channel. If you have any questions, please use the Q&A box at the bottom of your screen. If your question is addressed to a specific speaker, please indicate it while leaving the question. Let me now introduce Dr. Bharti Kulkarni, the convener of the Maternal Nutrition Technical Series. Madam is a Deputy Director and Scientist F at the ICMR NIN and the head of the Clinical Division Department. Her main research interests include maternal and child nutrition, anemia, body composition, and developmental origins of health and disease. Over to you, Madam.
Thank you, Rajni. Good evening and good morning, everyone. I'm very happy to welcome you all to this 7th e-dialogue in our monthly series of maternal nutrition e-dialogues, which are convened by ICMR National Institute of Nutrition as well as FOXI. For those who are attending the e-dialogue for the first time, let me tell you that we have had 6 excellent technical e-dialogues till now, starting from January this year. We covered important topics of public health importance, including maternal thinness, maternal obesity, maternal anemia, maternal well-being. We also had an excellent sessions on maternal diet as well as nutritional counseling. We had a very interesting session on how women's groups can be leveraged for improving maternal nutrition. And we are very encouraged by excellent feedback provided by the participants who participated in our previous programs. So today, we present to you the 7th webinar in this series on FIGO Nutrition Checklist. And we are very lucky to have a galaxy of speakers and panelists to tell us about the background of this work, the need for this checklist, the work that has gone into the development of the checklist, country-specific adaptations of the checklist, as well as some global health perspective on rolling out the this checklist for this universal nutritional risk assessment. We will also hear about the use of the checklist in the Indian context with some examples. We are truly honored to have with us Dr. Bipin Pandit, who has very kindly agreed to chair this session at a very short notice, despite his busy schedule. I'm very thankful to you, Dr. Pandit, for being with us today. And it's my privilege to introduce Dr. Pandit. He is the Vice President of FOXI and Chairman of Violence Against Doctors Cell of FOXI, Senior Obstetrician and Gynecologist and Director of Mukund Hospital in Mumbai in India. His special interest areas include laparoscopic surgery, infertility, high-risk pregnancy. Thank you very much, Dr. Pandit, for sparing your time today and being with us today. I would now like to invite you to give your opening remarks. Over to you, Dr. Pandit.
Thank you very much for your kind words. Good evening and good morning to all of you. On behalf of Professor Santa Kumari, our president of FOXI, and the team FOXI, I would like to welcome you here for this excellent subject and a webinar today. At the outset, I must thank Dr. Hema Divakar, our FIGO representative, and thank all the stakeholders in this program, including UNICEF, ICMR, Nutrition International, NIN, IFDRI, Alive and Thrive, and others for their active participation. I must also welcome and thank all the international and national faculty for their involvement and making this webinar, which I'm sure will be a great success. Despite its rapid economic growth, India faces an enormous challenge today of providing optimum nutrition to its 1.3 billion plus population. Malnutrition is a broad term that refers to all forms of poor nutrition. Malnutrition includes both undernutrition as well as overnutrition. It's not a condition affecting only poor, but it cuts across all socioeconomic groups across. With an aim to decrease malnutrition, India has implemented several nutritional interventions in last half century, including the National Food Security Act of 2013 and midday meal schemes. The Swasth Bharat Prerak program, a joint initiative, has helped more than 500 plus districts across India. Fighting malnutrition is a complex and diverse in a complex and diverse country like this is a very difficult and a challenging task. All the women, they have very important 3 phases in life. As a gynecologist, I can tell you, there's adolescence, there's pregnancy, and there is menopause. Nearly 53% of the women, 59% of the children, and 50% of the pregnant women are anemic. Anemia continues to be a significant public health concern. At the same time, children are malnourished and there's a lot of infectious diseases affecting them. We need to track the high-risk pregnancies and strengthen our health facilities. At the same time, newborn care of the infants and insisting and for the early implementation of the breastfeeding is very, very important. With the strengthening of maternal nutrition assessment and services in antenatal care in India, the goal is to equip nutritionists, gynecologists, and other professionals with the latest maternal nutrition interventions, strategies, and innovations. FOXI, as a powerful body of more than 37,000 members, have a very important role in this program. Prevention and treatment of undernutrition requires more than focus on nutrition alone, which is a very important part in prevention of many problems in pre-pregnancy, pregnancy, and post-pregnancy in women. I hope today's deliberations will enrich us in future policy decisions. Thank you very much for giving me this opportunity to be with you. Thank you.
Thank you very much, Dr. Pandit, for being here with us today and sharing your kind words. I now hand over to Rajati for further proceedings.
Thank you so much, Dr. Bharti. We are lucky to have Dr. Chandni Maria Jacob, a medical doctor now pursuing her PhD at the University of Southampton, UK, with us. She took the lead in organizing today's webinar and will now take over the session. Dr. Chandni, over to you.
Thank you very much, Dr. Rajni, for the introduction. Good evening and good afternoon, everyone, depending on where you're joining us from. Our first speaker today is Professor Mark Hansen. He is the director of the Institute of Developmental Sciences at the University of Southampton, and he's also chair of the Knowledge and Evidence Working Group at the Partnership of Maternal, Newborn and Child Health. He also co-chairs the Pregnancy, Obesity and Nutrition Initiative by FIGO. and will be talking to us today about the origins of the checklist and the priorities for maternal and child health. Over to you, Mark.
Thank you very much indeed, Chandni. I hope you can see my slides and hear me clearly.
Yes.
And just to welcome you to this, we hope, very influential webinar around the FIGO nutrition checklist. So I'm Mark Hansen, as Chandni said, and I was a leading member of the Pregnancy and Obesity Nutrition Initiative, or PONI, that FIGO set up some years ago. And it led to the development of the nutrition checklist. You'll be hearing later from Professor McAuliffe, and you've met Dr. Chandni, and you'll be hearing from Sarah Louise Killeen from Dublin, who were all instrumental in developing PONI. But I'm delighted that Dr. Yajnik and Dr. Ma are with us as well, because they were driving members of the checklist work that we did some years ago. So you know that obesity and nutrition is incredibly important in pregnancy. And our vision is that nutrition and appropriate weight should be at the front line of pregnancy care for every woman globally. So we want action on thinking nutrition and weight first at every contact. So how's that going to be done? Well, we think it could be achieved through guidelines, and many of these have been published by us and others. There's a special issue of the International Journal of Obstetrics and Gynecology last year on the PONI initiative. But it also requires resources, and today we're going to be talking very much about a practice resource, which is the nutrition checklist. That could feed through, and we hope it will, into advocacy. This being taken up by a range of organisations, not just FIGO, of course, but government and NGOs. And of course, it has important components for training as well. Our vision then is to give the gift of a life free from non-communicable diseases. Well, from what Dr. Pandit has told you, I don't think I really need this slide. You know the global challenge at NCDs, that they account for over 70% of deaths around the world every year. And sadly, more than 80% of these deaths occur in low to middle income countries, so parts of India, for example. As he said, malnutrition is inextricably linked to a range of conditions, including NCDs and their risk factors. And WHO data, this is a slightly old statistic, I suspect it's probably got worse since then, is that 1 in 3 people around the world suffer from some form of malnutrition. It might be undernutrition, which accounts for more than 3 million deaths every year, women and children, or it might be overnutrition, producing an increase in NCDs such as diabetes and hypertension. And of course, the combination of under followed by overnutrition, or mismatch as I like to call it, is really the double burden of malnutrition. And I know that Professor Yajnik is going to be telling you something about that later. But of course, and again, as Dr. Pandit said, we mustn't forget that there are specific nutrient deficiencies. And in fact, micronutrient deficiencies affect 2 billion people around the world. They're caused by inadequate or unbalanced diets. And in India, one would think very much of folate deficiency, vitamin B deficiency, iron, and possibly vitamin C in some groups. So of course, in 2015, the Sustainable Development Goals were launched, and 2 in particular address nutrition and weight in women as being absolutely essential for global health and development. Number 2, SDG 2, Zero Hunger, aims by 2030 to end all forms of malnutrition. This is a huge challenge. It requires addressing the nutritional needs of adolescent girls, pregnant and lactating women, as well as older persons, and as well as reducing stunting in children. So this focus on the early phase of life, which in a way followed some of the Millennium Development Goals, was nonetheless a new thrust which the United Nations and other organizations really championed. The goal, though, is to reduce by 1/3 the premature mortality from NCDs through prevention as well as treatment by 2030. It's a huge challenge, and to be honest, I don't think that the data shows that any country is on track to achieve this. But that's for a range of reasons, and one, of course, I'll come to in a moment. I like this kind of conceptual diagram, which shows how resilience, well-being and prosperity, the things that communities and populations require to develop, to achieve a better lifestyle, and for economic as well as health progress. It shows how it develops across the life course and how it's passed across generations. And we must remember that this is not just health, human capital, if you like, but it's also environmental capital, and of course it's economic capital too. So this starts at a particular place in conception in all of us. It builds up at a certain rate, achieves a peak, and then of course declines in middle to older age. That picture might be a high income country, and if we think then of a low to middle income country, some populations would tend to follow this red line. Children are conceived and start life in at a poorer place in terms of their potential resilience, well-being and prosperity. The rate of increase is slower, the plateau is lower, the rate of decline is faster. Then, of course, COVID came along, and that, of course, is one of the things that has knocked us off target for so many of the SDGs. And just 2 bullet points here for a story that you know better than I'm sure, in your context. Since the onset of COVID, coverage of life-saving health interventions and other access really to healthcare for women, children and adolescents in 36 low and middle income countries has dropped by nearly 25% in some places. So clearly women and their families are not able to access the healthcare that may help them. Coupled with that, 42 to 66 million people are now in extreme poverty. And as always, women, children and adolescents are more affected due to lack of social and financial protection. So this goes on to lead to an increase in food insecurity. So if we put that into my life course diagram, COVID is shifting everything downwards. It's doing so in high income countries, shown by the blue, and it's doing that even more so in low income countries, shown by the red. I don't know what the data here would be like for India, but for the United Kingdom, this gap, this shift down, if one thinks of life years lost, it's somewhere between 250,000 and 500,000 life years lost. That's substantially more than civilian life years lost in the Second World War. So even in a country like the UK, where we pride ourselves on having a very good health system, the cost, human, economic, humanitarian, is absolutely ghastly. So clearly we have to do something. And it's obvious from this graph, and this is one of the reasons that I like showing it, that the place to shift things up must be here in the early phases of life. This is where we need action, and it's where we need to work together, and in particular, we need your help. So what can we do? I hope at the end of the webinar that you'll be convinced that we need to extend the use of the FIGO nutrition checklist, ideally to every woman, ideally before pregnancy, but if not, certainly in the early pregnancy period. I will stop there, but Dr. Ranjini wants to pose a question for you, so I'll pass you back to her.
Thank you, Professor Mark. So we will have a quick poll right now. The poll question will appear now on your screen. So how often do women or couples take initiative to ask you questions related to nutrition in early pregnancy or preconception? If the question is not applicable to you, answer accordingly. You can choose only one option. I will end the poll now. So among the attendees who work in the healthcare settings, large percent felt that couples or mothers seek advice from you sometimes, not always. Thank you for sharing your thoughts. Dr. Chandni, over to you.
Thanks very much, Professor Hansen. Just a reminder to participants that you can add your questions in the Q&A box at the bottom if you have any for Mark. Our next speaker is Professor Fionnuala McAuliffe. Fionnuala is a professor of obstetrics and gynecology and the head of Women and Children's Health at National Maternity Hospital in Dublin, and she is the director of the UCD Perinatal Research Centre. She is also co-chair and founding member of the FIGO Pregnancy, Obesity and Nutrition Initiative, and she'll be talking more about PONI today. Thank you, Fionnuala.
Thank you, Chandni, for that lovely introduction. And I'm absolutely delighted to be here with you today. This is a fantastic collaboration between FOXI, UNICEF, FIGO, and the other organizations. And I particularly like to congratulate India, the way you really have prioritized nutrition understanding, perhaps in a way that a lot of other countries don't understand, that it's the absolute key to health across the life course. So together with Professor Moshe Hod and Professor Mark Hansen, we launched the FIGO Pregnancy, Obesity and Nutrition Initiative in 2018. As we've heard already, nutrition is vital for global health and sustainability, and really the key time to intervene is before and during pregnancy. So there are specific nutritional needs in pregnancy. Those of you that are looking after women in pregnancy will understand that there's increased requirement for macro and micronutrients. Before conception, of course, it's very important that there is the appropriate environment for the developing oocyte and embryo. And many of these are micronutrients: iron, B12, vitamin D, folate, and iodine. And these requirements increase with the developing baby, and of course, on into postpartum when the woman is breastfeeding. So there's significant requirement for mother to have the appropriate micronutrients on board before, during, and after pregnancy. And we've heard already that in low and middle income countries, the rates of undernutrition are very high, but also they are also very high in high income countries. And one of the big issues that we're facing is obesity across the globe. So we also in high income countries experience relatively high rates of malnutrition and overnutrition. So obesity is one of the manifestations of poor nutrition. And of course, many women who have a high BMI are in fact have very poor micronutrient status. And in most countries, obesity, which is a BMI over 30, is common, affecting up to 40% of women and older adolescents. And these are women of reproductive age. Why is high BMI important? Well, it can reduce fertility for the mother and increase gestational diabetes and hypertensive disorders. And for the fetus, it can increase stillbirth, congenital anomalies, large for dates, infant and growth restriction. And then, of course, across the life course, we know that infants that are born at higher or lower ends of the spectrum are at increased risk of obesity, diabetes, and hypertension themselves. So the key point to consider intervention across the life course, of course, is before an early pregnancy. And what we want to achieve here is to reduce chronic disease in the mother. We know that gestational diabetes is associated with a 50% chance of developing diabetes in later life. We know that pregnancy is a time where women often put on excessive weight. And of course, intervention will also improve the outcome for the baby. So you've heard already that the PONI initiative, which we were all very excited to launch, and we've had fantastic response and have had many webinars, both in India and across the world. We have a very ambitious vision that nutrition and weight are at the front line of pregnancy care. We want healthcare professionals to think nutrition and weight at every contact. We've just heard there from the poll that quite a number of women and families are seeking nutritional advice. So there is an awareness out there. And ultimately, we are aiming to give the gift of a life free from non-communicable and chronic disease. So an ambitious vision, but one that we're passionate about and feel that together we can achieve. So in last year, we published Pregnancy, Obesity and Nutrition Initiative supplement, including seven articles. I'd encourage you to go on and download these articles, which are free for download. In it, there are policy documents that will support your interaction with your government bodies, and also guidelines, and of course the FIGO nutrition checklist. The guidance for obesity care is very useful, and it covers pre-pregnancy, pregnancy and postpartum. And just looking at some of these pre-pregnancy, all women with a higher BMI should be encouraged to lose weight and to adopt a healthy lifestyle. So this is the recommendation before pregnancy, amongst other advice to take folic acid. During pregnancy, as you can imagine, there are many additional requirements, particularly around the care of women with a higher BMI, to ensure that they get the appropriate care in terms of diabetes and blood pressure issues. But also, again, they need to be given the appropriate nutritional advice and weight management advice. And again, postpartum, this is often an opportunity to discuss with a woman, perhaps in preparation for the next pregnancy, that it could be a time where she could perhaps lose weight, improve her diet in preparation for the next pregnancy. So I think most of us who are here at the webinar understand the importance of nutrition. We're looking after women on a daily basis with high BMI. So I think we understand it's important, but regular feedback across all countries, high and middle and low income, is that how do we start the conversation? How do we give this advice? There's no country that I'm aware of where a dietitian is available to all pregnant women. So it's up to us who are looking after pregnant women, obstetricians, midwives, and healthcare professionals to address this with women. And there's so many resources available, but really very few that are focused on pregnancy and that are suitable are accessible in a busy antenatal clinic. So with this in mind, the FIGO nutrition checklist was developed, and many of those who developed it are on the webinar here, and you'll see their names there mentioned. And it was, the idea of this was to make a nutrition assessment accessible. It's one page where the woman can fill out the questions, and then on the other side of the sheet, there is advice to healthcare professionals that they can immediately give the woman without reference to referring on to specialised care. So there's 4 sections. The first section is identifying any special diets. For example, many parts of the world, vegan and vegetarian diets are very common. To calculate body mass index, either the woman can do this herself or with her healthcare professional. And then looking at the quality of the diet. So it's yes, no, do they eat appropriate portions of these foods? And of course, this can be amended for vegan and vegetarian diets. And then the 4th section is looking at micronutrient status. And depending on the answer then, on the other side of the sheet, there is very simple advice that healthcare professionals can give to women there and then. So this really facilitates that conversation in the busy antenatal clinic, and this can be used before, during and after pregnancy. So, and this is a core component of our Pregnancy, Obesity and Nutrition Initiative, and we're hoping that with dissemination of the FIGO nutrition checklist, which was developed by many healthcare professionals, not just obstetricians, gynecologists, but scientists, nutrition specialists and public health specialists, that this will be a tool that healthcare professionals and women can use. And ultimately, our aim is to give the gift of a life free from non-communicable diseases. Thank you. And the next speaker, Sarah Louise Killeen, will go into more detail as to what we actually know about how effective the FIGO nutrition checklist is. Thank you.
Thank you so much, Professor McAuliffe. Our next speaker is Ms. Sarah Louise Killeen, who is a registered dietitian and PhD candidate at the University College Dublin and National Maternity Hospital in Dublin. She recently won the regional round of the Health Innovation Hub Ireland Award to take a digital version of the FIGO nutrition checklist forward. So we look forward to hearing from you about that.
Thank you so much for that introduction, Shandy. And I think it's clear from all of our speakers and the introductions today how important it is to address nutrition with women before and during pregnancy. So I am delighted that I have the opportunity to speak with you all today briefly about the FIGO nutrition checklist, and hoping that this will be a motivational 8 minutes for you. So really talking about what are the next steps, how can you make a difference by incorporating this checklist into your practice. So thank you so much for the opportunity. So just to recap on what Prof. McAuliffe has mentioned about the FIGO nutrition checklist, it is a one-page document that was developed by experts across obstetrics, gynecology, public health, nutrition, and other areas. So it's really evidence-based and informed by the previously published FIGO guidelines for maternal preconception adolescent nutrition. So the questions in the checklist really are based on the key aspects of nutrition for this time point, and it's free to download from figo.org. So it's ready to go for you now, and the aim is to facilitate nutrition counselling. So it collects information, and based on that information, that can help guide brief nutrition discussions with women as part of your routine practice. So the FIGO nutrition checklist will help you to give antenatal care in line with best practice. So the World Health Organization recommends that all women receive dietary counselling during pregnancy, so regardless of their BMI or other conditions. So everyone would benefit from healthy eating advice during pregnancy. But as we've heard so many times today already, low maternal BMI, high BMI, and anemia, among other micronutrient deficiencies, are a huge problem across the globe and in India as well. So really nutrition checklist will help address some of those issues, and the questions in the checklist and the whole approach really does align with the algorithms for maternal nutrition services, and I'm sure we're going to hear more about those later, so I'll keep it brief at the moment. Briefly, as Prof. McAuliffe said, I'm going to just touch base on what we know about the checklist so far in terms of the research. So, Prof. Ma is also on the line here, so he might talk about this in more detail. But to recap, his team published a study in our PONY supplement in the International Journal of Obstetrics and Gynecology, and in that study, it was a validation study with 156 healthy pregnant women in China, and they actually translated the FIGO nutrition checklist. It's a really good example of how the checklist can be adapted to regional requirements. And they asked women to complete a food frequency questionnaire. So that is one of the gold standard ways of checking what people are eating, so collecting detailed dietary information. And they correlated the answers in the checklist, so the women completed a checklist as well, with the data they collected from the food frequency questionnaire, and they found that they matched up quite well the intakes in the checklist and the intakes in the food frequency questionnaire, which means that the checklist, which is very brief, just one page, gives a good summary of what someone's eating. So it really is appropriate to guide nutrition conversations in a busy antenatal environment providing care. Probably most importantly, they found with the answers in the checklist, so the women completing it, 95% had at least one answer which would indicate some form of nutritional risk, so would indicate a suboptimal diet. So that just shows you how widespread nutritional issues are in a population of healthy women. And then colleagues in Italy did a study with the checklist, and they were looking at the checklist compared to outcomes. So they actually changed the answers to the checklist into numerical scores. So they gave a score from 0 to 10, and they found that lower quality diets, so lower scores, correlated with some outcomes such as pregnancy associated plasma protein A and placental volume. So this is just the first of hopefully many studies that look at the checklist and how the checklist can be used to perhaps predict outcomes and improve outcomes as well. So I think this is a great first step in looking at that. And also to note that they adapted the checklist. They added an additional question that suited the dietary guidelines in Italy. So this is another example of how you can take what is already available for you, the FIGO nutrition checklist, and adapt it to your local requirements. And then we did a study in Dublin in Ireland with the FIGO nutrition checklist. And because we've already seen it's validated compared to more robust dietary assessment methods, and there's some evidence to show that it's associated with outcomes in pregnancy, we wanted to see what is the feedback on using the checklist in a clinic setting. So we wanted to get the opinions of healthcare professionals using it, so obstetricians in a clinic, and also pregnant women in completing it. So we did an acceptability and feasibility study in an outpatient department. And we found, similar to Prof. Ma's team, we found that the majority of women reported a suboptimal diet. So the checklist really is effective in capturing briefly the presence of a suboptimal diet that may benefit from some intervention. And we found that it was acceptable to both women and healthcare professionals, and they recommended it for use, but time was identified as a barrier. So in terms of the future steps for the checklist, really hoping that today will motivate you to, number 4, execute. So really take what's available for you and to use it in your practice. We've been working on the research and also would encourage you to do the same. And through the webinar and other methods, we're promoting training of you how to use the checklist. And really the future could be evaluating it, looking at outcomes, looking at the impact of implementation in various clinic settings, and expanding. So this checklist at the moment is designed for pre-pregnancy or early pregnant women, but it has huge potential to be used as an adolescent checklist. It could be adapted to postpartum, or indeed postmenopausal, and really become a women's health checklist. So there's huge scope for a simple, brief dietary assessment method in improving widespread nutritional issues for women and children. To talk about the prize that we won for the checklist. So we've received funding to develop a web-page version of the FIGO nutrition checklist in Ireland. So we're going to collaborate with FIGO to develop this. And the benefits will be that it's interactive, meaning that you answer the questions. You can do that with the women in your care, or you can ask the women to complete it in advance. And based on the answers provided, the woman or yourself with the woman will receive feedback, personalized information. So it will really help you in advising on the answers that women give with the checklist. So you'll get the information in your hand. It's be really accessible because it'll be a web page, and it'll be accessible even without internet access. So that'll be great in supporting implementation globally, and will also be data generating. So we're going to design the checklist so it collects non-identifiable information, but we'll be able to use this information to understand global trends in maternal diet. So we can see different countries and what answers are coming up with the checklist, or what are the main areas to concern. And that will guide support and training and other areas. And then that'll be available, and you'll get a summary sheet. So that's what we're working on at the moment. So to date, we've had already 500 women across 4 studies, and we've done 3 webinars. This will be the 4th, reaching over 2,000 healthcare professionals. And our vision really is that this is taken up in over 130 countries. So I'm hoping that this is motivating you to take it on board. And how are you going to do this? It's free to download from figo.org, as I said, and I would encourage you to consider adapting it in different languages and also to your local dietary requirements if needed. Briefly, the algorithms have come up already, and I'm sure they will later in the day, but this is an adjunct to the algorithms. It doesn't replace what's in there, but really it supports nutrition assessment in part 1, and also the information collected at that step will inform what is discussed in steps 3 and 5. The checklist questions, as Fanula mentioned briefly, they cover dietary intakes. So there's meat and chicken, fruit and vegetables, fish, dairy, whole grain carbohydrates, and packaged snacks. And already this is suitable for some regions in India, like the West. As you can see, it lines with the diet charts there. But for areas where it doesn't suit at the moment, it's very easy to adapt it. And hopefully the online version of the checklist will support this even further. And you can see that you could swap out some of the meat and fish for other suitable options. And then finally, you can see that at the moment, some of the micronutrients are related to iron, so they match up quite well, but certainly you could add additional questions like they did in Italy, or adapt it as you see fit. So really, after today, I'm hoping that you will consider using the checklist in your practice and give a gift free of life free from chronic disease and that for future generations. So thank you so much.
Thank you very much, Sarah Louise. I'm pleased to introduce Professor Ronald Ma next. He's Professor and Head of Division of Endocrinology and Diabetes at the Chinese University of Hong Kong, and his interests and expertise are in diabetic complications, gestational diabetes, the DOHAD phenomenon, and PCOS, and he will be discussing how the checklist was used in Hong Kong. Thank you, Professor Ma.
Thank you very much, Dr. Channy, and thank you for the organizers for the kind invitation to join you. So I'm delighted to share with you our experience in trying to adapt the FIGO checklist that you've just heard about for local use in Hong Kong. So this audience, of course, is well familiar with the importance of maternal nutrition, but to put it in the context of where I work in China, we have a prevalence of diabetes of around 11% of the population, and around 15 to 20% of our women are affected by gestational diabetes. Of course, we now know that diabetes and other chronic disease is not really just a disease of adulthood, but as highlighted by Professor Mark Hansen, that really chronic disease often have origins early in life, with developmental origins of diabetes, including risk factors such as maternal obesity, maternal diabetes, and maternal undernutrition, which contributes to the lifelong risk of chronic disease such as diabetes. So it is important, therefore, to try to optimize maternal nutrition and also try to optimize the maternal intrauterine environment. But we are familiar with the challenges of trying to do proper dietary assessment in busy clinical practice, in particular antenatal care. Sort of the traditional way of evaluating diet requires complicated process of dietary recall, food records, 24-hour recall, or food frequency questionnaire capturing food intake over the last 3 months. These all need to be conducted by face-to-face interview, a complicated process that takes time to collect detailed data, which then needs to be coded into particular food items, and then even with sort of easier to assimilate scores such as DASH or Healthy Eating Index, these needs time to compute and therefore cannot really provide any feedback to the women or to clinician in the clinical setting. It is against this background that, as you've heard, that the FIGO nutrition checklist was developed in order to have a really easy to use tool that's self-administered, capture basic information, as well as information about quality of diet through 6 simple questions that you've heard from Professor McAuliffe. So a few years ago, we undertook this work to try to adapt the FIGO nutrition checklist for our local use in Hong Kong. And this is work led by Kit Ying Choi, who's a PhD candidate in our group with nutrition background and interest in maternal nutrition. So we aim to try to adapt the checklist with a translated version, and to also evaluate its utility by assessing association between the score on the nutrition checklist as when compared with well-validated dietary quality indices such as the DASH, the Mediterranean Diet Score, and the Dietary Quality Index International Score, and other nutritional indicators. We also wanted to compare and see if the nutritional checklist can identify women who have suboptimal diet. So what we did was Kit recruited, in collaboration with our obstetrician, Professor Wing Hong Tam, 160 women from the antenatal clinic. We targeted early pregnancy before 14 weeks, women who have singleton healthy pregnancy and were free of chronic disease or mental illness, and also they did not have any specific dietary restriction. All the women completed the FIGO nutrition checklist as well as the gold standard, the food frequency questionnaire, and also was followed up for pregnancy outcomes. So Kit conducted a detailed food frequency questionnaire. This was done to capture the frequency of different food items, beverages, and food. And this is aided by use of pictures to illustrate sort of size of portions, food models, and utensils. And this is the validated Chinese version of the food frequency questionnaire in use in Hong Kong. And you can see it basically addressed the different frequency of different items and also estimated the portion size. For the adaptation of FIGO nutrition checklist, we employed a professional translator to do the forward translation from English to traditional Chinese, and then also convened a committee including nurses, dietitians, nutritionists, team members from the research team to try to refine it, and also then did some validity testing involving mothers and pregnant women as well. So as illustrated before, the FIGO nutrition checklist included 6 main questions that are targeting specific food groups: meat or chicken intake, fruit, vegetables, fish, dairy products, and also packaged snacks, for example. So in terms of the questions, each of them in the questionnaire, in the checklist, it indicates particular diet nutritional indicators and also the nutrients that it's supposed to address. And also in the food frequency questionnaire, we matched it with the specific items from the food frequency questionnaire that would provide the similar information and try to compare the information collected through these 2 methods. We also computed well-validated quality indices: the Dietary Approach to Stop Hypertension, the DASH score, the Dietary Quality Index International, the DQII score, and the Mediterranean Diet score, which are all well-validated tools to evaluate quality of diet. And in general, the higher the score, the higher the adherence to that pattern of diet, and also the better the dietary pattern. So what we found? So KIT found that amongst the women recruited, the mean age was 33, with a mean BMI of 22.6, which is quite similar to our population, of our pregnant population. And 14% were affected by gestational diabetes, and about 50% had secondary education or below. When we compared the total score from the FIGO nutrition checklist against these 3 well-established dietary indices, we found weak to moderate correlation between the total score on the FIGO nutrition checklist with these indices, the DASH, the DQII, and less so with the Mediterranean score, which is not a commonly consumed dietary pattern in our population, showing that actually just a simple score collected from the FIGO nutrition checklist did show more, fairly moderate correlation to these indices. When we then look at the individual food groups captured through the FIGO nutritional checklist, we can see that, for example, the meat and chicken question actually did correlate, show weak to moderate correlation with nutrient intake assessed by the food frequency questionnaire in terms of protein intake as well as iron intake. And for sort of food group, for meat in general, also show weak to moderate correlation. The question on fruit or vegetables, again, show moderate to good correlation to fiber and vitamin C intake. And also the other questions such as the dairy question also did show moderate to good correlation with calcium intake or food intake for milk and milk products as assessed by the food frequency questionnaire. The whole grains again showed moderate correlation with whole grain intake. When the questionnaire is designed to identify women who have suboptimal diet by having answered to 1 or more questions saying that they do not have that good dietary pattern, and we then look to see if this was helpful in identifying individuals who have suboptimal diet. So you can see that individuals who score 6 and are considered to have good diet compare with individuals who have suboptimal diet. Those who score well on the FIGO nutrition checklist did have significantly higher score on the DASH, the DQII, but not so for the MDS, which again is not a common dietary pattern in our population. So whilst our study showed fairly good validity of the checklist, there were some limitations of our study, including the small sample size, the fact that these sort of studies are subject to recall bias, where in general there is underreporting of food that is conceived to be unhealthy. We did not incorporate nutrient biomarker analysis in the initial publication, though that work is now ongoing using archived blood. And also, for example, problems such as iodine deficiency, which is prevalent in our population, is not specifically addressed by the nutrition checklist. So we concluded that, in fact, the FIGO nutrition checklist, which is something that's simple and, as if you've heard, can be done in just 2 to 3 minutes, in fact, is reliable compared with gold standard, the food frequency questionnaire, which takes over 30 minutes to conduct. It also can identify women who have suboptimal dietary quality, and that this really is a simple and easy tool that can help us in busy clinical setting, including in antenatal care. So this work has been published as part of the FIGO pregnancy, obesity, nutrition supplement, as you've heard from Professor McAuliffe. And we're pleased that, in fact, we're now doing implementation of this, where Professor Tam is now incorporated the FIGO nutrition checklist in the antenatal program of our new Chinese University Medical Center, which actually just opened a few months ago, with maternity care service starting from October this year. And we're also in discussion with several collaborating centers in Beijing and Guangzhou who are also interested to incorporate the Chinese version into their clinical care. So hopefully, by trying to improve maternal nutrition, that this can be one of the pieces of work and efforts and approach that can try to interrupt this intergeneration cycle of diabetes and obesity, begetting diabetes and obesity. I'd like to just finish by acknowledging Kit Ying Choi, who led this work and analysis, our obstetrician colleague, Professor Wing Hong Tam, and our nutrition colleague, Dr. Ruth Chan, and also Professor Mark Hansen and Professor McAuliffe, and also Professor Hod and Dr. Divakar, members of the FIGO Pregnancy NCD Committee, and also in particular, members of the FIGO Adolescent Preconception Maternal Nutrition Work Group, led by Professor Mark Hansen, and also with Professor McAuliffe and also Professor Yachnik, who contributed to development of this nutrition checklist. And with that, I thank you for your kind attention, and I'll be happy to take questions later in the session. Thank you.
Thank you very much, Professor Ma. It's my pleasure to introduce Dr. Flavia Bustreo next. Flavia is the Vice Chair of Foundation Botnar and Chair of the Governance and Nomination Committee at the PMNCH, and she was formerly the Assistant Director General for Family, Women's and Children's Health for the World Health Organization. She's a strong advocate for the health and human rights of women and children, and so we look forward to hearing from you about the global health perspective. Thank you.
Thank you very much, Chadni and colleagues. And thank you especially to Dr. Kulkarni, Dr. Divakar, the FOGSI colleagues in India. It's really a delight to be joining you, even if virtually, for this important discussion on the FIGO checklist on nutrition. Chadni and colleagues, I have 3 main observations and then a couple of suggestions for how to take this work further. Number 1, on the importance of the work that you're doing. It's already several years, since 2010, when from the World Health Organization we were measuring the trends on maternal mortality reduction, that we observe what we call a growing trend of the so-called indirect causes of maternal death. And that, of course, includes obesity, diabetes, HIV/AIDS, and mental health. And this growing trend started first from countries like high income, like the UK, and the data that you show, Professor McAuliffe, are very indicative, but has also indicated progressively this trend in middle income countries and also in some low income countries. So all to say that the work that you're doing to really combat and prevent obesity in women, both before they become pregnant, during the pregnancy, and after the pregnancy, is a critical work. First point. Second point, when listening to the eloquent Professor Mark Hansen and his introduction, I think we have to all recognize that we have an important window that to do in order to do this work, which is the adolescence window, which is where we can have onset of many conditions that will affect women later in life, and the importance of a balanced diet, of physical exercise, the importance of combating, for example, eating disorders and bulimia, and all those aspects of nutrition that affect adolescents. This is a critical aspect that I would like to stress in this conversation. Second point, My third point is a congratulation for FIGO to taking this leadership and for giving a tool in the hands of the healthcare professionals, but also a reminder that currently in the global health arena and through, for example, through the Partnership for Maternal, Newborn and Child Health, and also the recent work of WHO, we are looking a lot at what we call the self-care movement. So to fully empower young women, adolescent women, and women during the course of their life to really be better able and better capable to do self-care. And so my plea is, as you further develop and refine this tool, could you look and think, how could a self-care tool look like? And what would it take to develop something that we can have in the hands of, particularly, as I said, of young women? That was my third point. My final thought is really a plea and a suggestion based on the experience having worked at the World Health Organization and having led the work of the Human Reproduction Program, is that you look at opportunities to work with these entities, and especially with the regional offices, with the country offices of the World Health Organization, to do a significant adaptation, because it was very clear, and the last presentation from Hong Kong clearly demonstrated that there is a significant need to adapt the FIGO nutrition checklist to the epidemiology of obesity and nutritional issues within the countries. Also, very important, the nutrition preferences, the dietary preferences that the population have, and of course the language and the kind of health system and platform for health system that includes the health worker that can provide and can administer the nutritional checklist. So all of that to say, please, and I'm sure in the later part of the dialogue we'll have some other colleagues, but anything that we can do to connect this excellent work that you're doing with these organizations that have a global reach, in order to ensure that we can have spread of such a valuable tool to benefit health and well-being of many more girls and women in the world. Thank you very much, Admi, and thanks again for having invited me to share some reflection.
Thank you very much, Dr. Pastoria. Those are some great points. Our next speaker is Professor Chittaranjan Yajnik. He is the director of the Diabetes Unit at KEM Hospital in Pune, and he's also the founder member and the vice president of SNEHA in India, which is the Society for Natal Effects on Health in Adults, as well as a founder member of the International DOHAT Society. And he will be discussing the checklist in the Indian context. Over to you, Professor Yajnik. I think you may be muted, Dr. Yajnik.
Okay, sorry. Sorry. Okay, thank you, Chandni, and welcome everybody. I'm Dr. Yajnik from KEM Hospital, Pune, and I'm a diabetes specialist. So my views will be in some ways driven by the diabetes requirements in this. I'm fond of saying that mine is the only diabetes unit anywhere in the world where the logo is mother and the baby. And that's because of initial interest in gestational diabetes and into DOHAD when David Barker came and trained us on this. The second logo is the modern Ganesh, who instead of traveling on the back of this mouse, now clicks the mice and moves very fast. And that's the rapid transition we have in India, and that's driving a whole lot of requirements as well as the outcomes. So I think I'm not going to speak much about the checklist because a lot has been said. and there are different aspects to it. But I'm going to say now the need for personalized approach is becoming more and more apparent because of the rapid transition in India. And I'm going to try and highlight our findings in that. So if you look at this picture, I mean, the diversity in India is enormous. There are 40 odd states. There are so many different cultures and tribes. It's very, very diverse and very, very individualized sort of approach which will be necessary. And this, I think, is a major issue when we apply any checklist. And I think some research and application to the individual groups or the individuals will be very necessary. And if we look at the food, I was stunned to see this on net actually, that the Indian food is so diverse that actually giving an advice about different food items to make up the requirements and balance the calories and the micronutrients would require some efforts. And I think that should be one of the major aims for the people involved in this. The other issue which Professor Mark Hansen mentioned and said I was going to, is the double burden of malnutrition. And this was again a Lancet consultation, and I was part of it. And it was driven by Jonathan Wales and Alessandro Domea from WHO. And we had a great time actually putting things together. And we realized that there is so much to it that actually there is a lot of biology which we can learn and apply in practice to improve the outcomes by way of double duty actions. I'm going to show you a slide in the Pune maternal nutrition study, which, as you know, is now almost 30-year-old. And we have 3-generation data in this. And I'm going to highlight you some of the interesting findings, okay, how a pregnant woman in the F0 generation, which we studied between 1993 and 96, and her daughter, whom we studied between 2015 and 2020, how do they look, how do they match, and how do they differ? The age at marriage for the mother was 18 years, and for age at daughter in these first 150 deliveries was 19.3, a significant 2-year increase, which of course is good for the baby, good for the mother, and perhaps still a bit too young given the 19.3 years of age. Education, very rewarding increase in education between 2 generations. 7 more years in the school for the daughter than the mother. And actually in the F0 generation, 1/3 of the mothers were illiterate. Now I can say in the F1 generation, there's no illiterate girl. This was mainly primiparas here, so that's actually just the design of the study. Height, 5 centimeter increase in height between mother and daughter, very rewarding. Body mass index at 28 weeks of gestation, 20 for the mother, 21.5 for the daughter. 1.5 kg per meter square increase in 1 generation. But if we compare this to an average Western pregnancy, you will be able to see the difference. Where do we lie on the spectrum? Gestational diabetes. In the original study, we diagnosed less than 1% women to have gestational diabetes by the then prevalent WHO criteria. Now we are using IADPSG criteria, and 19% of the daughters had gestational diabetes. The fasting glucose in the daughter was 10 milligrams higher, half a millimole. And the 2-hour glucose in the glucose tolerance test was an amazing, like say from 75 to 115, almost 40 milligrams higher. So plus 30.5. Insulin levels were higher in the daughter, and that converted, actually, given the higher glucoses, into a lower disposition index, indicating that in the daughter, the beta cells were working less efficiently than in the mother. So this is an amazing story within one generation. Within 25 years, the height has increased, the weight has increased, education has increased, but so has glucose, so have lipids, and the beta cell function has gone down. Vitamin B12, which is my favorite nutrient, actually improved because of our efforts, and also because many of these daughters were part of our B12 intervention trial. Now, what happened to their babies? In the F1 generation, there were, like, say, birth weight was 25-50 grams on average. So that is what these F1 mothers were at birth, 25-50. And if we were to calculate low birth weight, that would be approximately 35%. And if we were to calculate SGA, small for gestational age, more than 50% of these were small for gestational age. Within one generation, the birth weight has increased between the mother and the daughter. Now I'm talking of F2 daughter, by 250 grams, which is a whopping increase actually. If we look at all the dietary trial, and if we look at Mumbai maternal nutrition study, which started preconceptionally and introduced sort of high nutrient diet, micronutrient diet, the rise in birth weight was 40 grams. Here we are seeing 250 grams. And even for the male child, it was plus 200 grams compared to the mother, though that's slightly unfair comparison. Length increased, head circumference increased, so did abdominal circumference. But very interestingly, the sum of skin folds is lower in the daughter compared to the mother at birth. So 8.2 instead of 8.4. And this to me is a very rewarding sign. I don't know who should take credit for this, but perhaps our micronutrient intervention might have contributed a little bit at least to this. So I've shown you quite remarkable findings of change within one generation, within one family, from mother to the daughter and to the granddaughter of the original mother. So what might be the factors? And I have no intention of discussing this slide, just to show you that we put together a lot of data by many months of actually investigation to say what various biological, social, and other factors might contribute to the double burden and the side effects of that. And I think those of you who are interested, especially students, postgraduates, please go to Lancet and read this paper and the interesting construct which Jonathan Wales did. So I put this together almost 10 years ago as part of actually the International UN meeting for Women and Health, that taking the idea from Norbert Frankel, who was studying diabetic pregnancies in America, where he said excess fuel transfer from the mother to the baby leads to fuel-mediated teratogenesis. Usually we use word teratogenesis for abnormalities of development and disfigured sort of outcomes. He used this for metabolic and body size outcomes. In India, I coined the term nutrient-mediated teratogenesis, which is because of undernutrition. And from Pune maternal nutrition study, as you know, we described the thin fat Indian baby born to an undernourished mother. And if there were no development, that cycle would continue with less of diabetes and gestational diabetes like there was in the last generation. But within one generation, these daughter here, actually, this picture was made by Caroline Fall about 30 years ago. We have traced her and she is now moving on this motorbike. So this very poor family has now moved into this situation. And as I showed you in the mother and the daughter, there is a combination of undernutrition on micronutrient side and overnutrition on the macronutrient side. And this contributes to a dual teratogenesis, which is really a complex situation. At 18 years of age, 20% of the girls in the F1 generation and 38% of the boys in the F1 generation had pre-diabetes by American Diabetes Association criteria. And what were the associations of pre-diabetes at 18 years of age? There was a combination of factors, undernutrition in early life and some overnutrition either in early life or later on. So short birth length and small head circumference were strong predictors of pre-diabetes at 18 years of age. Mother was non-overweight. That means the BMI was less than overweight, and female sex was an additional risk factor from the undernutrition side. From the overnutrition side, though the mother herself was underweight, her own plasma glucose in the pregnancy in the higher normal range predicted pre-diabetes in the child. So as I said, there was only less than 1% of gestational diabetes by international criteria, but highest tertile of glucose in the mother within normal range was associated with increased risk of pre-diabetes, paternal glucose for daughters, and for the male, adiposity at 18 years of age was contributing to the risk of pre-diabetes. So such a complex picture of early life undernutrition with a degree of overnutrition from maternal fuel and subsequent adiposity in the male gathered in the puberty. So it's a very complex picture. So way forward for us is, of course, everyone has stressed education. We need to convert these messages into our service, but not forget the research. Because for more than one reasons, Indians are many times different than the rest of the world. And I think FOXI and IDA can get together to convert these brilliant sort of FIGO checklist and customize it to the Indian situation. And I think some work will be needed. We made a film on educating the people about good maternal nutrition for her own pregnancy's benefit and for the benefit of the child. And this has become a very popular film. We have more than 1 million hits on our site. And I'm just going to show you a 2-minute teaser, which we actually put on to attract people. I hope this works now. Okay, it worked in the morning when I worked. Now it's not working. Right. Thank you very much. It was just a 2-minute teaser. It's a 25-minute film. It's been enormously popular. And I think many, many mother-in-laws and mothers have learned from it and learned how the taboos in the India have actually worked to produce low birth weight babies. So we are using this on a wide scale, and I would invite Foxy and Ira to actually adapt it to their students and to their clientele to spread it. So that's it. Thank you very much.
Thank you very much, Professor Yagnik. I now welcome Dr. Sameer Pawar, who is a nutrition specialist at UNICEF in Madhya Pradesh, India. And he will be discussing the use of a nutrition algorithm in the Indian antenatal care context, which has been tested in Madhya Pradesh. Thank you, Dr. Pawar.
Good evening and good morning, depending on wherever you are. And thank you very much, NIN, ICMR, FOXY, FIGO, and all the partners for providing us this opportunity to share a few things from our state of Madhya Pradesh within India. And I'm sure it's very difficult to talk after Dr. Yagnik with that great insights on how we are progressing over the generations. But what I'm trying to do now is basically moving from a research-based setting or a quite an individualized setting to a public health system, which is run by government, the state government of Madhya Pradesh, and how the government, with the support of partners, tried to really, incorporate a systematic way of improving antenatal care quality using the algorithms within the system. So this is more of a work done by government of Madhya Pradesh with support of the different development partners, including UNICEF and Nutrition International. And I'm just trying to share it very quickly on what we have done, the process part of it, rather than the outcomes or the impact that we could achieve out of it. So coming to antenatal care services in Madhya Pradesh, what was the situation when we had started somewhere in 2018, 2019? So we had the package which actually involved everything that we think that should be done during pregnancy, including registration, all sorts of tests, all sorts of supplementation, counseling, conditional cash transfers. And where do we provide these services? There are two platforms which are used. Those are health facilities as well as something called as Village Health Sanitation and Nutrition Day in India. It's a platform at the village level wherein services are provided on a monthly basis through an outreach kind of a service by the nurses. So these are the two platforms through which these services were provided. But there were a few challenges that were noticed. And some of the challenges are mentioned here. I would like to draw your attention towards the missing or inadequately implemented components, and which involved a lot of nutrition related interventions that were probably missing or were inadequately implemented. It did have, you know, weight and height measurement, but didn't really look at nutrition assessment and identifying the risk that mother runs through with the kind of nutritional status mother has. It had weight measurement, but didn't really calculate gestational weight and didn't really look at, you know, weight change in weight over the period to understand the progress of the pregnancy. So we tried to build these components within the existing antenatal services that are provided through these platforms, and we tried to take the health systems approach. So looking at all the pillars of the health system strengthening and trying to plug in gaps in each of those pillars so that we are able to, you know, provide comprehensive services to the beneficiaries on the ground. So the first thing that was done was the algorithm that was adapted to the local situation, and it made the whole package more comprehensive, looking at all the aspects of, you know, testing and classifying and treating. I'll come to the details of that algorithm, but it was piloted in one district wherein we looked at both platforms, the health facilities as well as village health and nutrition sanitation days, and also some of the other health facilities in other districts that which were chosen for pilot. It also involved, you know, supply assessment and plugging gaps for, you know, supplies that were that are very, very critical if you look at nutrition point of view or maternal nutrition point of view. It also involved a lot of capacity building of the field staff, and then creating tools for them to really deliver these services or deliver these interventions effectively. We tried to use existing registers, existing mechanisms for record keeping as well as for reporting, so that there is no additional burden on the public health system for data entry or reporting. And everything was actually budgeted within government PIP with technical support from the partners. So this was the approach that was taken in Madhya Pradesh, and here is the algorithm that was actually used. So I'm just sharing the principle of the algorithm here. So it involves screening of pregnant women for health and nutritional risk, and screening means we take up these 4 boxes. We ask for something, we measure something, we look for some signs, and we test for some of the things, and those are mentioned here in details. Based on what we find in from these 4 boxes, we classify the risk that mother has, and accordingly mother is provided services in terms of supplementation, counseling, or management of the condition if it is required. Now, moving forward, these are the algorithms that are basically used. Of course, they are translated and adapted to the local language that is spoken in Madhya Pradesh, which is Hindi. And the algorithm is basically separate for health facility services and separate for outreach services through VHNDs. Algorithm also talks about who provides what. If you see, you will see ANM is responsible for the boxes 1, 2, 3, 4, while medical officer is responsible for the actions in box number 5. So this is the algorithm that was used for health facilities. This is the algorithm that was used for village health nutrition sanitation day at the village level. The basic difference is you have outreach workers who are available at the village level. So based on that, the boxes were divided among the outreach workers. If you see, the first box is the responsibility of the nurse and the ASHA that we have at the village level, while box number 2 and 3 is more about ASHA and Anganwadi workers doing together, and box number 4 and 5 is again a nurse providing those services. That's the basic difference between the 2 algorithms. Not only algorithm, there was need for context specific counseling material that needs to be used. As Dr. Yagnik said, it is quite individualized services that are needed when we look at diversity within India. So hence, for Madhya Pradesh related dietary recipes, different material were prepared and used specifically for counseling for the mothers. Now, it's just the work in progress that had started a year ago. And if we look at the initial results, I'm just mentioning results based on what we see from the existing indicators that we have. You will see that, you know, the intervention district that was Vidisha, you will see some of the indicators much better than the rest of the average of the state. But what I am interested in is some of the newer things that were started, and after 6 months of intervention, how nurses are finding them useful, or how are they able to do it on ground. If you see the box in the right corner, it shows that, you know, MUAC, the mid upper arm circumference for pregnant women, was newly introduced, and you can see that 92% of nurses are now quite comfortable in measuring mid upper arm circumference and accordingly counseling the mothers based on their nutritional status. As I said, if you see calculating gestational weight gain and counseling mothers based on the change in weight gain, you will see that it is still quite less, and 42% women nurses are doing it at the moment. It is also good to see that 68% of the nurses are now able to identify and record high-risk pregnant women more effectively in their system, and providing services specific for the risk that they are carrying, so that they are able to really impact on the pregnancy outcomes. Now, if I put it in a nutshell, what is the gain that the system has achieved by doing this? While we'll analyze and we'll monitor for the details of this the implementation, what I see from the initial things is basically we are able to really integrate the missing components, and especially the maternal nutrition related components which were missing. We are able to integrate it in the system. It has the algorithm based implementation has really eased the way they are implementing the program, and it has also renewed focus on routine antenatal care. If you have noticed, in India, a lot of stress was there on the health facility based antenatal care services, and the routine ANC in the villages was missing, or was not up to the mark. And this particular initiative has really pushed that to improve upon the routine antenatal care services and nearer to the family in the community. Systematic delivery has been achieved, and there has been quite an improvement in terms of quality of services that are provided as these algorithms are being used. And then, of course, the capacities of the field level functionaries to deliver these services has improved quite remarkably over the period of time as we introduce these algorithms. It also helped in strengthening the health system as a whole in terms of kind of services that are provided through the system. This is not the checklist, but this is algorithm, and adding the checklist with this algorithm would further improve the quality of services and the kind of services provided to the pregnant women. And then we look forward to introducing further the checklist along with this algorithm to strengthen maternal nutrition components within antenatal care. Thank you very much.
Thank you very much, Dr. Pawar. My sincere thanks to all the speakers for a thought-provoking and interesting series of talks. I will now hand over to our moderator for the panel discussion, Professor Hema Divakar. She is a senior consultant obstetrician and gynecologist with decades of experience and expertise in women's health. She is also vice chair of the FIGO Pregnancy NCDs Committee, medical director at Divakar Specialty Hospital, and the chairman of ARTIST, which is a training institute for skill transfers. Thank you and welcome to the panel discussion.
Thank you, Chandni. Namaskar. And there's a message in the chat box which says, fabulous presentations and discussions. And who has said that? None other than Dr. Dinesh Baswal. And so we all join you on behalf of all the viewers to re-endorse and resonate the same comments that you have made. And he also continues to ask, it looks so simple. what is holding us back from implementing this? Yes, ladies and gentlemen, one action is better than 1,000 intentions. And it is none other than Dr. Baswal's, whose office we visited in the ministry with Professor Mojay Hood, the chair of the Pregnancy and NCD Committee of FIGO, and very proudly gave him the Pony Declaration, multiple copies of that, and that triggered off our connections with Vani Sethi from UNICEF, and then with Mark Hansen, Finola, Sarah, Chandni, Donald, and the rest of our team from FIGO, whom I'm very, very grateful to for all the insights they have given us in helping us move forward. So we've begun this long journey, and we have more questions to ask. And for this, we not only urge all our previous speakers, but we welcome two other stalwarts who have joined us, especially for this panel. Professor Sharon Norris, who is a professorial fellow, research professor at the University of Witwatersrand, South Africa, director of the South African Medical Research Council Developmental Pathways for the Health Unit, and BSI NRF Center of Excellence in Human Development. Welcome, Professor Norris. Also joined by our very beloved Professor Jagmeet Madan, who is the president of the Indian Dietetic Association, principal and professor, Department of Food and Nutrition and Dietetics, Savitala Thakre College of Home Science, and the SNDT Women's University, Mumbai. And as urged by none other than Dr. Yagnik, yes, we need people like her to join hands with us to get this movement forward. And let me begin by asking Professor Norris and Jagmeet the first set of challenges and questions. Professor Norris, we would like especially to know from you about your work around how these maternal comorbidities have had an impact on the pregnancy outcomes, both long-term problems for the mother and the immediate short-term and the intermediate-term problem for the children as well. And aha, we say on looking at you, because we want you to give us some insights into AAHA, which expands as Accelerated Action for Health of Adolescents. Professor Norris, in our country, yes, even the target population of the pregnancy don't show up for antenatal checks. And it is indeed our vision moving forward that we must get to the adolescents to prepare them for pregnancy. Otherwise, we are clearly missing the opportunity and missing the bus, as how I may say. So, Professor Norris, all yours to respond to these two very interesting pieces of work that you're doing. Let us have you share them with us and we'll learn our lessons. Norris, please.
Thank you very much. Thank you for the invitation to be part of this. And I echo your sentiments. It's been fantastic to hear all those presentations and the different viewpoints and the practicalities. It's how do we move to actual action on these concepts. So really three things. So tackling your two questions and then just a point of reflection. So my work is mainly in South Africa, and like with India, we are clearly in the midst of the double burden of malnutrition. We're still dealing with a legacy of infectious disease and undernutrition, but now with an escalation of non-communicable disease with obesity. And so unfortunately, when women present at our antenatal clinics, we've seen more and more of these women having comorbidities. So then, and I think it's important, particularly for not only researchers, but clinicians in the antenatal space, is that we've got to make way for the reality of we can't be siloed. Women are going to present now with more complexity in their morbidity profile, be it anemia or obesity or infection or coupling of all of these. And so slowly but surely we are seeing that the multimorbidity profile is having potential effects for pregnancy outcomes, particularly prematurity and small for gestational age and impacting birth weight. And obviously these have both shorter and longer term consequences for the mother, but also for the offspring. And so gestational diabetes is, and as we've heard, is a really good example to show that it's a condition that happens during pregnancy through probably a variety of morbidities. It disappears in most cases postnatally, but it's a real significant risk factor in the sense that these women often, within 5 years, a large proportion of them transition to type 2 diabetes. And we're now seeing more and more that the offspring consequences is not just only linked to obesity or diabetes risk within the kind of 10 to 15 year period postnatally, but we're also starting to see cognitive deficits linked to gestational diabetes pregnancy. So clearly what happens in that period matters, and thinking of how we improve nutrition or tackle these morbidity issues in the short-term antenatal clinic setting, but also postnatally is important. So coming back to the second question, which is around the WHO AHA, which was an effort to try and collate our best evidence of nutrition and health in the adolescent space. And this is now several years ago that this initial document presented, and it was used to really try and engage the member states to try and get adolescent nutrition and health on the agenda. And as we've heard, adolescence in that preconception period is critical. It sets up not just trajectories for the adolescent into adulthood and their future health, but also has this potential to impact the intergenerational development of their offspring. So quite a critical window of opportunity. So my point of reflection really is that we know from Dohad, Yashnik's work and such, clearly a life course of consequence following the 1,000 days and in the preconception. I think the FIGO tool gives us a way to try and operationalize and bring nutrition to the fore in our discussion with women, be that preconception, during pregnancy or postnatally, and gives us some tools to try and help guide that. The point that I really particularly thought was interesting was the point around self-care. And it's indeed, that's the way to go. So part of the responsibility is not always just on the health professional. We have to empower women to take part of that responsibility for themselves, and that self-care component, and linked potentially to elements of the nutrition, FIGO nutrition checklist, is providing additional resources that could be more self-directed, would be potentially a way to augment some of that self-care thinking into the application of the checklist. However, my one big caveat that I'd like to put out there, and I don't have the answer, so it's really just back to the panel and back to the team, is we know that there are incredibly difficult structural and contextual factors that really make the provision of health as a priority not important. So women in the preconception period, health is just not a critical concern. There's too many other things they are having to deal with, grapple with, from food insecurity to complex vulnerabilities in the social way, to relationships, to families, to peers. It's just an enormous amount in vulnerable communities that women face and have to deal with day to day. Now to put on a pressure to get their health in order sometimes seems a step too far. Women are a bit more motivated during pregnancy because now they're concerned about the baby, and we probably could get good traction in that period. But what we find postnatally is women just go back to the cycle where it's about the baby and care and less about herself again. And, you know, this interpartum period may be another critical period because possibly a couple of years later she'll have another child. So as much as we're dealing with individuals, we've got to recognize that there are incredible inequalities, social, structural factors that put difficulties in the lives that women face. And if we don't remove those, there's constantly going to be a battle that health is going to be a struggle for individuals to focus on. So I'll pause there. Thank you.
Yeah, thank you so much, Professor Norris, because such a crucial factor that you mentioned. It's not all about a one-track dealing with the doctor and the patient and the food, but we have to break the silos, and there are so many other factors influencing the behavior, as you may call it. But I may also add that sensitizing the healthcare providers, the very importance of this whole issue also is crucial, because many times when they seek our help, if they do seek our help, there is a tendency to just, push it under the carpet, pass it away. Oh, it's not so important, but you've got this, that, and the other. Let's pay attention to that, for example. So I think it's, both ways we have to meet at a common point. And I take your point on AHA. Thank you so very much for joining us. Some of these gender-based and the inequity questions I will be, of course, directing to Flavia a little later during the panel discussion. So now over to Jagmeet ji. I particularly want to ask you, when we say that we have to be responsible for our own health, how do you see the consumer behavior? Do they actually look at what the package of food really contains? Do they pay attention to that? Do they even care to understand that they must pay attention to that? That's the first question. The second is about the, it's a big country, but not all can be trained and speak in a uniform manner to translate what we are thinking to the girls and women out there. So the NutriSoft software, go digital is the mantra. So maybe that may play a very crucial role moving forward with the digital technology and artificial intelligence, guiding our girls and women constantly. That's the hope for the future. So almonds and adolescents and more. Jagmeet ji, over to you.
So very good evening and good afternoon to everyone here. Thank you, Dr. Hema. Thank you, Dr. Bharti, Dr. Chandni, Dr. Rajni, the collaborators, NIN, ICMR, Foxy, FIGO, Pony. I think I'm really happy to be here, and extremely humbling to hear Dr. Yajnik's not only the presentation, I mean, it's always inspiring, his work, but, his statement that, we as an association, because I'm here in two capacities, one as a national president of Indian Dietetic Association, and two, I'm also heading an educational institution where I deal with, adolescents and young adults. And I think, to me, this FIGO checklist, what I really appreciate is that it says pre-pregnant and early pregnant women. So I think, to my mind, it's the pre-pregnant, age group, which is very, very important. And Dr. Hema, if you will permit me, I would just like to share a couple of slides based on some of the data which we've collected in the city of Mumbai, just to give you a glimpse of, where we are in terms of this pre-pregnant age group which we are looking at.
Sure.
So just give me a second.
Yeah.
I will share my screen. Yeah.
Yeah. I think Rajni, yes. Thank you.
Can you see my screen? Can you see
yes,
my
screen?
Yeah.
Yes,
Okay.
yes.
Okay. So this is just to set the context, and I think we can discuss a whole lot of things because very, very important points have been made. So like I said, pre-pregnancy is a very, very crucial stage to intervene, more important than early pregnancy. And let me tell you right at the outset, if you go to the ANC setup in India, a lot of women, report to ANC only in the second trimester. We completely missed the first trimester where the women is reporting to ANC. So for us, I think reaching out to the pre-pregnancy age group, which is the adolescents and young adult, is very, very important, and intervening early would arrest the damage and favor positive results. So I look at it as a window of opportunity. And the question which I want to probably answer from some of the data which we have collected, and can a dietary intervention really help, is just a couple of slides I want to share with all of you, because we've just finished collating this data, and we've published our main paper in the Frontiers in Nutrition, June 2021. So first, I just want to share some of the cross-sectional data which we collected with 1,300 adolescents and young adults in the age group of 17 to 25 years in Mumbai city. And let me outset place on record that this was a collaborative effort of my institutional research cell, SVT research cell, with Kasturba Health Research Society Medical Research Center, which is headed by Dr. Shobha Udupi. So some of this data is not published, but I wish to share some of these results with you, but we are in the process of publishing it. So what we observed, that out of these 1,310 adolescents and young adults which were screened, the elevated fasting insulin was observed in 9%, and almost 31% had elevated 2 hours stimulated insulin. So they were already hyperinsulinemic. And what I wish to add here is that, all these adolescent and women, adolescent and young adults, almost 25% were undernourished, and obesity and overweight was to the extent of 25 to 30%. But with normal BMI, low BMI, they showed, hyperinsulinemia. And when we looked at the two categories of normoglycemic and normoinsulinemic and compare it with hyperinsulinemic and hyperglycemic, we found a significant difference in the BMI, waist circumference, waist to height ratio, body fat, visceral fat, and the high blood pressure in the category 4. When we did the regression analysis, what came out again very clearly was that it was the overweight and obesity and body fat which was the most important factor which related with hyperglycemia and hyperinsulinemia. What made the whole observation very interesting was that when we studied their snacking pattern, we found that majority of them were not only snacking, but snacking unhealthy. Almost 90% were consuming HFSS snacks and 30% ultra processed snacks. And when we went one step further, we could find that the snackers, there was a direct correlation between snackers and higher body fat, hyperinsulinemia, and high HbA1c. And, of course, there was complete ignorance about what they were consuming, and there was a need to sensitize them towards quality eating. So, so this is just to show you that, how snackers versus non-snackers, more amount of obesity, higher body fat, and higher waist to height ratio, and hyperinsulinemia in that group, and HbA1c, which of course was not statistically significant. So we took this opportunity to go one step further to plan a food-based intervention. And of course, we used, it was a randomized controlled trial, open label. And, that was the age group of 16 to 25. And we had the inclusion criteria, exclusion criteria. And the intervention group got, about 56 grams of almonds, which is about 2 handfuls of almonds for a period of 90 days versus a control group, which got a cereal pulse mix control snack, which was isocaloric. And, all the measurements were taken and the dietary data was collected, and all the biochemical parameters, including the lipid profile and inflammatory markers were assessed. So out of 1,313 individuals, 429 met the inclusion criteria, so they were pre-diabetic, and 265 consented to participate, out of which 219 completed the trial, and 107 were in the almond group, and control group had 112. And what we found was that, the HbA1c significantly decreased in the almond group as compared to the control group. The, hyperinsulinemia also appreciably decreased in the almond group. When we look at the lipid profile, there was a significant decrease in the cholesterol, LDL, and also a significant decrease in the inflammatory marker, especially IL-6, and a significant decrease in the triglyceride to HDL ratio. When we looked at their body composition, we found that there was a significant increase in the body fat in the control group. However, if you see that there was no difference in the weight and the BMI of the two groups. And when we did a subgroup analysis, wherein we looked at, individuals from almond group and control group who did lose body fat, we found that the almond group showed a significantly higher decrease in total cholesterol, HDL, and highly sensitive CRP. And there was a appreciable decrease in the IL-6, which is an inflammatory marker. So this is just to highlight that if we replace the HFSS snacks with a food-based intervention, which is nutrient dense, which are like natural nuts, I think it is making a lot of difference to the cardiometabolic risk factors and the inflammatory environment in the body of these young adults. So when we look at the FIGO checklist, I think it is brilliant because what gets emphasized in FIGO checklist is the prioritizing of nutrition in the whole mapping, and which I heard the previous presentation as well, that somewhere we were probably missing it at the ANC level. The only thing which I wish to add to the discussion, and maybe we can take some of these points further, is that India, like Dr. Yajnik said, is a very unique country. It is not only diverse, but we also see, lean obesity. We see lean obesity at low BMI, normal BMI. Even when I was looking at the FIGO checklist, I think we should try and sensitize, customize that checklist to the healthy Indian thali, so that, besides just asking which food groups they consume, they also get to understand how much that food group needs to be emphasized. Snacking pattern for young adult is very, very important to capture. Another point which I want to make is that antenatal care settings in India are very varied, starting from ICDS centers to the government hospitals, to the private hospitals, to the nursing home. Then again, the variations which come at the rural, urban, or the tribal level. Then the education level of the mother, the socioeconomic strata, the local, regional, seasonal customization in line with the important nutrients in pregnancy, because there are very many locally available, seasonally available foods, which are rich in some of the nutrients which are emphasized during pregnancy. And we must not forget that Indians are very, very particular about using some special foods during pregnancy. So I think customization of the FIGO checklist vis-a-vis the FFQ state-wise. I mean, what we have seen other countries doing, I think in India, it cannot be just one FFQ. It has to be a region-based FFQ, and vetting the FIGO checklist with that, which will make sense. And I think this is where I'd like to stop, and we can take the discussion forward.
Thank you so much, Jagmeet. I bring you back to that question on, do the consumers really read the labeling? And it resonates with Vani Sethi's question in the chat box, that the kind of advertisements and the tempting fast food and the wrong kind of eating that happens with the snacking of the adolescent, coming together was the first thing. We are into a serious dialogue every month with the e-dialogues. And do you think that the way forward would be to influence the regulatory authorities in some manner to have a hold on all of these? What are your thoughts on that?
Yeah. So I think I'm on two panels of FSSAI. One is food fortification and the other is labeling and claims. And I think government is very clear on the mandate of coming very heavily on HFSS snacks. So there is, they're looking at front of pack label formats, which are more user friendly, because the studies in the past suggest that in India, in totality, people don't read labels, okay? Number two, the way labeling is done is not that user friendly. So, so using a traffic light or using formats which immediately convey messages to the consumer, I think this is where government is in discussion. So I think latest development is that they have given, I mean, they're undertaking a study basically on this specific aspect to test different formats of the label and what works in an Indian environment. So that is definitely the case. And the second thing is that, like what was said very rightly by Dr. Norris, that, you know, the early and pre-pregnancy or the adolescents and young adults, food is the lowest priority to them. You know, so they're really not concerned in terms of what is the quality eating which is going in their diet on day-to-day basis. And we have done some collection of data where we clearly see that, you know, 60% of their total intake is snacks. Okay, so they're not in a meal kind of a pattern, they're into snacking. And if they are not guided, if they're not provided with the right options, I think, you know, they are really damaging their internal environment. And if, you know, this kind of young adults are going in for pregnancy, I think they're entering that crucial phase in a very, very, you know, compromised state of internal environment, which is not good.
Thank you so much, Jagmeet. I have shifted over to Mark because Mark, myself and Chandni had a discussion with an organization called GAIN, and it is still our unfinished agenda, if I may say, Mark, that there was some conversations about connecting with organizations like Eat Right, and you know, there was another distinguished speaker on one of our e-dialogues who said youth for youth. You know, the youth promote the right kind of eating for the own peers, and an egg a day keeps, you know, there's some, you know, buzz around how the quality proteins should get into the young adolescents and ideas like that. So Mark, my question to you is, again, one of our, you know, very dream and unfinished agenda was the opportunity to get the youth of our country together into a massive program like the one you have in your Lifelab. So tell us more about how impactful your work at Lifelab has been and what lessons can we take from there to make some things happen in our country.
Oh, thanks, Hemaji. I'm mindful of time, and colleagues may need to get on with their Friday evening and so on. I think what you've touched on there, and what Professor Jagmet's touched on, is the fact that there's another agenda here, and Flavia mentioned this too, which is we have to engage young people. In a way, with the checklist, we've been talking very much about engaging obstetrics and gynecology specialists, possibly outreach workers. And I think we need to think about the next steps in terms of how we take that forward, whether, as Flavia says, it's linking to a WHO regional office, whether it's perhaps linking into the algorithms and trying to see how we can operationalize that more. But I think it would be good for a small team after this meeting to come up with some very clear bullets on how we can take that forward. But I think what we've uncovered is the fact that, yes, we need to think about engaging adolescents in new ways. It may be that the kind of Lifelab science literacy for health kind of awareness raising thing we do in Southampton can be adopted and adapted in other areas. I don't know, but I'm almost beginning to wonder whether you need another one of these meetings to address that kind of issue, especially in India, where so many pregnancies are in adolescence and where you've got a highly engaged, highly connected community, even if they're not connected with the things that we're talking about, which is their health and their nutrition.
Yeah, thank you, Mark, because there is a lot more work cut out for us for sure, and we will put our heads together to do something better and something more. So at the start, Rajni and Bharti said that this is a mix of the target audience who are, you know, from various segments of healthcare providers, and Deepa Thakur asked, can a female who is 30-year-old deliver a healthy baby? So that's the kind of question with so much of complications being portrayed. So in the metro cities in our own country, yes, 30, 32, 35 has been the common age group that we are dealing with, and the care, of course, as Jagmeet said, is different at different levels, but we are paying attention to all the comorbidities that can coexist, but we are thinking nutrition first, that's for sure. So Pramila Menon, her question, let me direct that to Fionnuala. These are the COVID times and we cannot escape a question which is not around COVID. The trends are that preterm births and low birth weight babies, you know, are more in the COVID affected women. What do you think the underlying cause could be? Is it something to related to nutrition? And in fact, health is wealth. When Norris said that priority may not be the health, COVID situation certainly has brought the buzz in the forefront, where everybody is now paying more attention to their immune system, how it works, and the healthy food that they can eat, etc. So, Fionnuala, the comment about preterm, low birth weight babies in COVID times.
Thanks, Hema, and that's a great question. So we know that COVID can cause inflammation of the placenta, called placentitis, and in women with COVID, we have seen increased rates of stillbirth, preterm birth, and growth restrictions. So it is a major concern. How that relates to maternal nutrition, of course, high BMI is a particular risk factor for poor outcome in COVID and pregnancy. So when we look at women who required admission to ICU and ventilatory support, high BMI was a particular risk factor, and maternal age. So I think that's where maternal nutrition comes in. We know that high BMI is a pro-inflammatory state, and of course COVID is a pro-inflammatory state. So I think those two conditions colliding have resulted in higher rates of preterm birth. So I think the interesting thing about high BMI is it's affecting everybody across the world. Traditionally, it was high-income countries, but in fact, we're seeing it now in low and middle-income countries. So I think by when we see women before pregnancy or any time during the reproductive life, we need to look at their weight and feel that we can advise them on the importance of losing weight.
Just a small follow-up question, Fionnuala. What are the challenges even out there in your part of the world for the postpartum care? Because we define three distinct, periods: pre-pregnancy, pregnancy, and postpartum. It's like out of sight, out of mind. And do the women really come back to get some more guidance about the nutrition-related stuff?
Yeah, so we're now considering postpartum as the fourth trimester to sort of bring it in a little bit more. Because of course, when the baby's delivered, mum and baby's healthy, we're delighted, clap ourselves on the back and move on to the next pregnant woman. But the postpartum period in most countries there's very few routine visits. Women go home from hospital and are never seen again by healthcare professionals. So this is a real opportunity to capture women before the next pregnancy. Maybe they had gestational diabetes, blood pressure problems, put on some weight. And I think they're quite motivated. And of course, they are breastfeeding as well. So the nutritional demands of lactating women, as you know, far exceed those of pregnant women. So I think we could certainly do a lot more with that fourth trimester.
Right, because when we say pre-pregnancy, to many clinicians' mind, it is prior to the first pregnancy. But inter-pregnancy also becomes pre-pregnancy for her subsequent pregnancy, and that needs to be paid a lot more attention to. So I move on to Sarah now. Anshita Patel asks you, Sarah, checklist you've given, you've discovered 95% suboptimal, etc., etc. How do we train people, or how much more efforts will it take? Because even simple things like the portion size and what they, how they have to tune their food. If you have found something from the checklist, how do you guide them next to get onto the optimal column?
Yeah, thank you for that question. It's a really good point. And I think that there could be some hesitation with people to ask questions about nutrition and to use a checklist if they're concerned that they might not know what to say if they identify any nutrition issues. So the checklist asks about questions which were identified in the research as being key for pregnancy nutrition. And then at the back of the checklist, there's information that corresponds to each of those questions. So if, let's say, the question on meat and chicken intake comes out with an answer of no, which would indicate there might be some risks in terms of protein and other vitamins and minerals, those are identified at the back of the checklist. So the healthcare provider has that information to know what types of nutrients might be of concern, and then moving that forward to advising on food portion sizes or other options for that food intake, and even things like further, like you're saying, the chewing and things that can be done using locally available resources like the diet charts in India, or in other regions there will be appropriate diet sheets. So the checklist is really the nutrition assessment piece. It's just to help you to gather the information in a really simple way and to guide you of what could be areas to talk about, and you can use that to use the resources for counselling in an efficient and simple way.
Thank you, Sarah. But when you flip it over and read those and then guide your patients, do oftentimes the dietitians clash with the advice that is given in the simplest of the manner? Do they say, oh, you haven't said this, that, and the other? How do they respond to what we have put on the back side of the checklist?
Yeah, that's an interesting question. So my background is dietetic, so I'm a dietitian, and I think from looking at the checklist, it does have the key areas that are the most important for pregnancy nutrition. And there's certainly things that you can add, and we've seen in some of the research that different regions have felt they wanted to add certain questions for key nutrients for their region, but it does have the core things that are important for pregnancy across the board. So definitely it's dietitian approved in that sense. And then you can add further in terms of the counselling on it.
Thank you, Sarah. I think we should take Jagmeet's advice very, very seriously, and Jagmeet ji from IDA and Foxy has to absolutely get together to do something more on this entire initiative to actually get it out to the people there. Next, I move to my beloved friend, Ronald Ma. Ronald, you said that even the university has, now started using the FIGO checklist. My question to you is that at the first visit, you have identified this, that, and the other, and you have guided them to just make some changes in the checklist. Do you have a mechanism where they remain motivated to follow what has been advised? And is there a follow-up of, the same patients who may have adhered to what your advice has been, or many of them may just not bother? What is your, what are your insights into that point?
Thank you for the important question. So, the first phase of work that we've done is really just trying to work out how we can use the checklist to identify women with nutritional problems. So the initial research that Kit did was focused on trying to adapt it for the local setting, the language, and also seeing if it works, which we think has clinical utility. So now we are trying to then bring it to clinical use. So for the previous women that we evaluated, we did not give any feedback at the same time, because at the time it was a process of collecting the data and to evaluate whether it works. So now we're in the process of trying to incorporate that into clinical practice. So this new antenatal care service that our obstetrician colleague, Professor Tam, is leading at our medical center, this is now being incorporated together with sort of a care package that include referring these women to nutritional advice. We're also thinking of how to incorporate this in some kind of platform that at least provides, because of course, any effort that requires one-on-one nutritional counseling is not going to work on a big scale. So we're also thinking of how to adapt this or incorporate it in some kind of either portal or app to try to at least provide some feedback in a more timely manner, and also engage the women sort of through the pregnancy course. And of course, hopefully later on at earlier stage, sort of before they actually contemplate pregnancy. But to actually then provide feedback during the pregnancy. And of course, then this becomes an integral part of maternity care and not just that this is a one-off thing. So this has to fit into sort of other aspects of antenatal care. So for example, when we actually recruited these women, we did it at the time of the Down syndrome screening visit that they attended. That was a time when they were all sitting around waiting to go for tests and for blood tests. And that's when we actually recruited and did the assessment. And that seems a good time to at least evaluate the sort of diet pattern early in pregnancy, to at least try to address some of these dietary issues, even though, of course, it would have been even better to have identified them before they were pregnant. But at least this is one time point we've identified that in our local practice that we could try to be a point of contact and potential intervention.
So point well taken, Ronald, to when you must begin. So you began right, and there's a lot more work to do, but you know, we hope that the new innovations and the digital transformation which is happening across the world, inclusive of the developing countries like ours, will quite be of a great facilitator for many more things that we want to do going forward. So thank you very much. So Flavia, on to you about empowering women. We know that at least in parts of Asia, definitely for our country, most of the women still, though the new generation is changing very rapidly, but women eat the least and eat the last. And contrary to their usual lifestyle of eating last and the least, only during pregnancy, they're suddenly pampered into eating too many things, which may not be the right thing to do. So the gender inequity is very, very evident. So what are some of the objective ways where we can turn the situation around to let them know what's important and why and when? And have you had, can you give us some insights into that?
Well, thank you so much. And let me say that up front, I really support the idea that Professor Hanson has made in this final phase of our conversation, that we have a further dialogue where we invite young people and we invite especially young women, because one clear lessons that we have learned on empowering young women is that they have to be at the table and they have very particular perspective. Now on the issue of nutrition and empowering young women of nutrition, we also need to consider, and this is the lessons from the US, the impact that on the choices, on the nutritional choices, the marketing strategy of fast food companies have had. And we have seen, for example, in the US, that the marketing has made the message inclusive of if you eat fast food, you are free, you have more time, you don't have to be cooking like your grandma was, and so you are free. And I would want to understand in the Indian context, is that a message also that is passing to the young Indian women that are coming into life, that, you know, not cooking, looking at the fast food, snacking in between and having a different nutrition style that the ancestors had, if that means being emancipated, being more free. And that's the only way that we can do that, Dr. Divakar, as you know, is to involve them and to involve. You have amazing young Indian leaders. I've met some of them in the climate change arena, in the gender empowerment. So engaging them, I think, is an absolutely first step. And then also using different methods for engaging them. And they are clearly, our conversation has been about using the digital technology, using the social media, using means that young people communicate with themselves and influence themselves. That I think is also quite crucial. Over to you, and thank you so much again.
Thank you, Flavia. Thank you for acknowledging about the fresh thinking and new frontiers in the Indian context as well, because it's really the new India where the newer generation need to be involved, because our perspectives may be quite different than the reality, especially in the furthermore years to come. So we will take that point on board and get the insights into what better we could be doing for the healthy generation next. So thank you so much. Now, Megha and Marty, both of them are asking Dr. Yagnik. Healthy Mother, Healthy Babies is an organization which Marty runs, and Megha has also asked, does Yagnik have any experience whatsoever with the use of the FIGO checklist? Because if he started using this, maybe he'll give a point or two on how we adapt it to the Indian context, what are the challenges or limitations in the use of these kind of checklists, which may be our first action point coming to thinking nutrition and acting upon it. Dr. Yagnik.
Yeah, I'm sorry. I mean, I haven't begun with the checklist, FIGO checklist, and I answered on the board there. Okay, that's what we are just now negotiating with the hospital obstetricians and the village clinic which we have. To just, I mean, I read Ron's paper, Ron Ma's paper with great interest, and now I know Fiona also has done very similar thing there. So we should learn from them and really do this fast. But I have to say I haven't done it as yet.
Absolutely.
So I was just too involved in so many things.
Yeah, and Dr. Yagnik, if I may say, every OBGYNs, when we ask about Dr. Chittaranjan Yagnik, they say, oh, we've seen his photograph, because the famous photo of the thin fat Indian, which is flashed all over, that's all that they seem to know and remember. But you're absolutely fantastic work over the years. So you've clearly proved that generation to generation. So another question also was the influence of the BMI and the translating factor into the stunting and undernutrition and its effect. How do you think we should handle the issue of such a tsunami of the hyperglycemia or the diabetes in the generation next?
Yeah.
Where should
okay.
we place the
So in the Pune maternal nutrition study, as I said, 20% of the girls and almost 40% of boys had pre-diabetes at 18 years. And 2 out of 3 pre-diabetes girls had a BMI less than 18.5. So they were actually undernourished by the WHO classification, and 1 out of 3 boys. The overweight obese category, if we go by international criteria, 25 and above, 4% of girls and 8% of boys. So clearly these international criteria don't apply to us. That's absolutely true. If we are able to measure body fat, that might be one step ahead. In the field, simpler things to measure might be actually waist circumference in relation to either hip or height, like Dr. Madan showed. So that is another possibility. But I think we pay too much attention to Western cut points. And that actually, I think, makes us miss many of the comorbidities which we are discussing. Now, to me, that also raises some interesting questions for which I am not very famous. I just wonder whether this intergenerational increase in glucose and lipids in daughters who are 5 centimeters taller and 1.5 BMI heavier than the mothers, but still very much. Is this actually a nature's mechanism to improve fetal growth? And then we declare that they have GDM and then again bring them back, because treatment for GDM is actually to reduce the calorie intake, reduce the carbohydrates, etc., etc. So I have to admit that actually we need some deeper thinking, deeper analysis of the data which we have got. And there is such a big sickness industry around GDM that it has become really a big issue to really make or think in any other way. And also because we have all these national bodies and this and that, down with GDM, I'm finding it very difficult to even set up a study, because current standard of practice is to diagnose it at a particular level and then treat it. So it's very difficult to even set up studies. So what I would suggest is we should also think about the natural evolution of a condition in a population over generations. And I always show this slide from a Danish philosopher, where he says life can be only understood by looking backwards. And for India, between 1830 and 1980, 150 years, which are also almost the period of occupation, we gained 0 centimeters in height when Europeans gained 15 centimeters in height. And since 1980, as I showed, the girl or daughter in our study gained 5 centimeter height compared to mother. Is this too rapid a progress? And that is bringing problem. So it's actually needs some more involved thinking with various experts and keeping in mind the natural history of the condition in relation to history, as well as we calling it comorbidity.
Yes.
So I'm just expressing my own confusion.
Sure.
It might confuse people more coming from me, but I am at a stage where I'm seriously thinking, okay, what should be our approach? And what is the correct way for the double duty action, and the famous thing to say, do no harm. Because now I'm analyzing 1,000 diabetic pregnancies which we have treated in last 15 years. And the small for gestational age in diabetic pregnancies is still between 15 to 25%. So I think we really need to think about this.
Thank you so much, Dr. Yagnik, because honest answers and deep thinking and the kind of thinking that people like you can do, we respect that, and we would want to apply our minds to revisit this entire situation and re-brainstorm about the Asians in particular being quite different and how we need to look at our population and figure out a way forward. But though the FIGO nutrition checklist looks so simple, that's something immediately we will implement to get some data on the table, but the background situation or the whole issue is so complex, as you have just laid it out in front of us. It really calls for a cautious and deeper and penetrating approach to doing better than what we have already done at the surface level. So thank you so much for that. My last question to the one who has actually walked the talk, implemented the initiative in the region of Madhya Pradesh, Dr. Sameer Pawarji. The question to you from Neha is it easy to adapt these FIGO checklists? And Dr. Baswal also asked, how are you planning to scale this up? because you've done it in one district and you have proven to us that you can do it. So your thoughts and insights.
So first of all, just a clarification, we did not really implement the checklist as such directly, but we implemented the algorithm in its principles. So, but what I think as a fallout of this discussion is basically once the algorithm is used, they are probably ready for now, using the checklist on top of the algorithm, so that it will help them further to identify issues and address them as they identify the issues, especially related to diet and nutrition among pregnancies. So for Madhya Pradesh, it is now scaled up in additional 7 districts. So scaled up means government putting funding for capacity building of their system, of their functionaries, and the trainings have been conducted in 8 aspirational districts of Madhya Pradesh as of now. And government also has a plan to scale it up to all 52 districts, and they have secured funding for the same. So as far as training goes, there is a scope now to train across the state in 52 districts. And what I'm thinking is, with the help of this forum, I take this discussion forward with the government of Madhya Pradesh to also add in the checklist part of it, so that it becomes further systematic and further easier for the ground level staff to really implement the components in its principle and spirit. Thank you.
Yeah, thank you so much, Dr. Pawar, because people like you give us the hope that, where there is a will, there is a way, otherwise there are only excuses. So thank you for being on the panel. And in the closing, I must especially acknowledge the efforts of Chandni and Rajni, the duo who have paid attention to micro details in putting us all together, with the overarching support, of course, from Bhartiji, Vani, and the rest of the collaborators, inclusive of many, many organizations who have come forward with a sincere intent. And every e-dialogue session, the entire faculty, they're just an email away or a phone call away. And we sincerely appreciate their wholehearted participation, sharing their experiences, which have helped us learn many a lesson. And we promise, on behalf of this entire consortium, that we will take this movement forward to have a healthy generation next. And yes, we will give them what they truly deserve. Namaste.
Namaste. Thank you so much. Thank you.
Rajni? One more poll question was there, I think, Rajni.
Yeah. Yes, we have 91 participants. So if you agree, I will launch the poll. Yeah.
Yeah, please.
So please. This is just a simple feedback we wanted. Yeah. I will end the poll now. So thank you very much, all the speakers, panelists, everyone. So you have motivated us, and all along with all the attendees, we feel that if it is available in our local language and adapted to our local diets, we would definitely use it in our settings. Thank you very much.
Super. This is the best positive takeaway. Thank you so much, everyone. Thank you.
Bye-bye. Thank you so much, everyone. I am sure all our participants would agree that this has been a huge learning experience. And I wish to thank all the speakers, Professor Mark Hansen, Professor Ronald Ma, Professor Fionnuala, Sarah, Dr. Samir Pawar, Professor Shen Norris, Professor Jagdeep Madan, for their excellent presentations and insightful discussions. I wish to thank Chandni for bringing us together.
I wish to tell you that we will be coming up next week with an announcement for our next webinar, which will happen on the last Friday of the next month. Thank you so much for your enthusiastic participation. Thank you one and all.
Thank you.